Thank you, Miguel, for such a pleasant introduction. First of all, I would like to thank you and to thank the organizing committee and to thank Sergio Barroso for his invitation to attend this fruitful meeting and to in this such lovely place and to hear such fantastic data and so well educated oncologists. I'm surprised because you know in France we are so late regarding this fantastic interview and audits. So impressive, very impressive. So these are my disclosures, and as you see, as a thrombologist, I'm working with all the partners, hunting and beating the clot, which is a hard task for each one. And here's the agenda. I would like just in around 20 minutes to convince you that cancer is a natural prothrombotic disease with a multifactorial basis, and all the recommendations are leading to consensual treatment for a long period of these frail patients, with cancer patients. And we are going to see why low-molecular heparins are such the best antithrombotic strategy in these patients. And at last, but not the least, the unmet needs, because we are going to see that the implementation of this recommendation, unless in Portugal, are not so good, and we need more education and, of course, to help of such group as the JustCat. So there's an intimate relationship between cancer and thrombosis, and as you see here, the tumor cell are able to promote tissue factor and carcinoma messen's release, and therefore to induce prothrombotic syndrome with a multifactorial collaboration with numerous cells and plasma proteins, and therefore inducing inflammation. And this hypercoagulable state is leading to both angiogenesis, tumor growth, and of course metastatic spread. So we know that it's a risky relation, thrombosis and cancer. That's for since many, many years. But in fact, we know that cancer patients are very heterogeneous. And you see that the prevalence is reaching 20%, which is very important. And we know that compared to non-cancer patients, that the recurrence, postoperative DVT, it's much more frequent in cancer patients. But thrombosis is a marker of a poor prognosis. And we know that thrombosis is the second cause of mortality in cancer, and that it's avoidable and preventable. The risk factors for thrombosis in cancer are linked to the cancer type, histological type of cancer, the site of cancer. And you see here in this North American case control study that pancreatic cancer, stomach cancer, lung cancer are the most aggressive in these ambulatory patients, with a prevalence of 13% in 6 months, which is huge. But pay attention also to the timing, and you see that the most frequent incidence of thrombosis in cancer patients is in the 3 or 6 first months after the cancer diagnosis. So that's occurrence is linked to the tumor mass and to the cancer treatment. And we know that these factors are associated, cancer factors, patient factors, treatment factors, and the weight of these factors is different, but their association is synergistic. 1 + 1 is always over 2. But we are talking about solid cancer, but you have to pay attention also to the liquid cancer. And you see that here in multiple myeloma, that thrombosis is also linked to a poor prognosis. And you see, in case of any thrombosis, in case of venous thrombosis or arterial thrombosis, the risk of death is significantly increased in these patients with thrombosis, 1 year, 5 years, or 10 years after diagnosis. So we have to think about the consequences, to think that in case of thrombosis in cancer, the patient had an increased morbid mortality, of course, an increase of bleeding risk because they are frail patients, and the antithrombotic treatment is always associated to a bleeding risk, but also to think about the sequelae of venous thrombosis with post-thrombotic syndrome, with pulmonary hypertension, and also the loss of chance for the cancer patient, because we have to stop his anti-cancer treatment. And this delay, it's not a good prognosis. And of course, there is an increase of healthcare costs. So that's why the cancer-associated thrombosis prevention and treatment are, of course, an ethical challenge, but also an economical challenge. And these are underlined by all the recommendations, North American, European, French, Italian, and so on. So you see that in case of cancer patients, hospitalized patients, they should have, all of them, thromboprophylaxis. But what about outpatients, ambulatory patients? And you see, again, there is no routine thromboprophylaxis for these patients. However, you have to consider low molecular weight heparin thromboprophylaxis in one case-by-case basis in this patient to select the high-risk patients and to give them such thromboprophylaxis. That's true for solid tumors, but also for multiple myeloma. And this stratification, this selection should be based on a risk assessment tool. And Corana, which is a North American guy, has proposed a very simple risk assessment. You see, you select here just the site of cancer, give him here 2 for pancreas, 1 for, let's say, lymphoma, and therefore you pay attention to the hemogram parameters, platelet count, hemoglobin level, leukocyte count. And therefore, if the score is over 3, the risk of DVT is at 7% at 3 months, which is huge. The Australian guys has proposed another scoring, adding to Corona score 2 other parameters, D-dimers and P-selectin, soluble P-selectin. P-selectin is like a biological glue promoting the interaction between the vascular blood cells, and therefore these heterocomplexes are triggering thrombosis in cancer patients. And you see that if this glue is increased, so you have a prevalence of 35% a year of thrombosis and not 4%. So it's, I think, a good hook to detect high-risk thrombosis in cancer patients. So that's why you have to be a good profiler and to stratify the risk based on factors linked to the patient, linked to the cancer, linked to the treatment of the cancer, and of course, linked to the vascular compartment, to the biological way, and therefore it's a 4-dimension process. And you have to see your patient through these 4 dimensions. As an example, you see here for the multiple myeloma, if there is no risk factors, still in this multiple myeloma, some patients should receive low molecular weight heparin prophylaxis. But in case of the existence of more than 2 risk factors or hospitalization, this prophylaxis is mandatory and therefore is maintained during 3 to 6 months. What about treatment of thrombosis in cancer patients? And you see again that here it's a long-term low molecular weight heparin treatment, and the optimal duration is 6 months. 6 months. And you have to use these low molecular weight heparins once daily. It's possible. It's more comfortable for the patient, but you have to pay attention to the dose. And the dose are not always available for each one of these low molecular weight heparins. So pay attention to the type of heparin and to the dose of heparin to get such efficacy and safety. And you see that if you have to choose between unfractionated and low molecular weight heparin, you have to choose the lowest one, the light one, because it seems more efficacious and more safer. And therefore, there is a reduction of 30% of mortality using low molecular weight heparin than unfractionated heparin. So let's say the lowest, the kindest, and the safest. What about vitamin K antagonists? In this Cochrane review, you see that the low-molecular heparins are more efficacious to reduce the VTE recurrence in cancer patients than vitamin K antagonists, with no price to pay regarding bleeding risk. So the clinical benefit is in favor of low-molecular heparins. Why? Because we know that low-molecular heparins are not only anticoagulants, they are able also to have other possibilities, other biological activities which are not anticoagulants, releasing TFPI, reducing the cell adhesion molecules, having a non-inflammatory impact with reducing the cytokines, and here also stabilizing the extracellular matrix, inhibiting such enzymes. So that's why in various experimental models, they proved that low-molecular heparins got antitumoral actions, able to inhibit thrombin, therefore angiogenesis, able to inhibit heparinases, so to limit the metastatic spread, inhibiting the glue, the P-selectin heterocomplexes formation, and therefore inhibiting the bush-like clot, protecting tumor cells against cytotoxicity of natural killers. So you see that heparin and low-molecular heparins are able to reduce the thrombogenicity and to limit the development of cancer cells. So that's why these molecules are Swiss knife model molecules, and therefore we have a multifocal effect using these drugs in this context. What about incidental thrombosis? So you see that as symptomatic venous thromboembolism, it occurs in the first month after cancer diagnosis. So you have to treat them in the same manner as the classical symptomatic VTE. What about in case of recurrence? In case of recurrence, if you were under vitamin K antagonist, you have to switch to full dose low-molecular heparin. If you were under low-molecular heparin, you have to increase the dose of low-molecular heparin by 20 to 25%. So you have to push the syringe and to increase the dose of low-molecular heparins, which is still the best tool to kill the clot in these patients. What about the case of thrombocytopenia? The threshold, the level, it's 50 giga per liter. If you are over this threshold, you still use full dose of low-molecular heparin. If you are below this threshold, you have, if needed, to transfuse patients with platelets. And if you are not able to maintain this threshold, so you have to reduce the dose of low-molecular heparin or to stop, to hold the anticoagulation because the bleeding risk is higher. And it's not ethical to accept such bleeding risk. What about the targeted specific oral anticoagulants? The new ones, the oral ones. We are attracted to do that, but it's a wrong thing because you see that all the anti-cancer drugs are substrates of the same enzymes metabolizing these new drugs. So there are numerous interactions with these pathways. Moreover, cancer patients has got many comorbidities and co-medications. So that's why, regarding the renal impairment in these patients, there is a risk of accumulation, a risk of variability regarding pharmacokinetic, pharmacodynamic parameters, and we have to pay attention to that. Moreover, the clinical studies promoting the use of these drugs in cancer patients are regarding a very low proportion of cancer patients, with less than 4%, and these cancer patients were not so well defined, weren't so well characterized. And in fact, you see that patients has got previous cancer and they're not active cancer. So I think we have to pay attention to this heterogeneity. And that's why that's why the experts recommend to not use such drug for this moment in this context of cancer. What about the adherence of guidelines? You see that in France, for example, in, let's say, severe patients at metastatic stage, regarding the guidelines, only half of the patients were in agreement, receiving the right dose with the right drug. And it's the same in Spain, in Italy, or in other registry in France. So half of patients receive what they have to receive. So we have to pay attention to that, maybe to educate practitioners. You have seen that the risk of thrombosis varies with the cancer evolution. And that's why you have to evaluate in a regular manner this risk, profiling your patient, and modifying the shield in face to the enemy you are going to beat. And you know Mary Poppins and the magic word she said. I think that the new word you have to say as oncologists is stratify chronothromboprophylaxis to maintain your patients in a good way. So what about the perception of the patient and the physician regarding the administration of low molecular weight heparins for a long period? You see here, if you ask, for example, would you say that injectable or oral are more appropriate to diseases that are severe, extremely severe, or very severe? They both, patient and physicians, are in agreement to say they rely more on injectable than on oral. And do you think that these drugs are very effective or somewhat effective? Again, they rely both on the injectable more than on the oral. And regarding the treatment, the long period treatment, how long would you agree to be treated with an injectable or an oral that was prescribed by your physician? And you see that here, the 50% of patients accept to be treated for a long period, 6 or more than 2 months, or more than 6 months, and only 10% of the physicians thought that. So there is a huge gap between the patient view and the physician view regarding the strategy and the antithrombotic strategy. And the first thing to do is to talk to your patient and to ask your patient and to get the opinion of your patient before deciding for them. So cancer is a clear induced acquired prothrombotic disease, and the thrombotic process leads to the tumor proliferation. One profit to the other. It's like a Janus. It's the same, it's a double phase, same disease. And the low molecular weight heparin is the first line and the best choice today to use that and to beat the enemy, which is thrombosis in cancer patients, for the prevention and for the treatment of thrombosis in these patients. And with such drug, you are, let's say, with a diamond-like approach, you are facing all the phases of the pathology in this complex situation. So at the end, and I think that you have to be advised to stratify in an adapted way and to decide the prophylaxis to put in balance the risk of bleeding and the risk of thrombosis, and to prescribe to the high-risk patient and to prohibit to the weak-risk patients. And therefore, I think, as said my friend Jean-Claude Van Damme, in thrombosis of cancer, stay aware. That's, I think, a good choice.